Hello friends. So now the INI-CET exam is over and I hope all of you did your level best. Now before we go ahead and discuss the radiology questions, let's have a quick look at the exam pattern. Now this year exam was different. Why? Because there were a lot of questions which were asked from first year subjects, second year subjects, from subjects like ophthalmology and ENT, and short subjects like radiology, like psychiatry, like dermatology, they were asked in a much lesser fashion. Now, this is in complete contradiction to what we saw in NEET PG, where short subjects were asked heavily, specifically radiology. This year, radiology had meager 5 to 6 questions, which we're going to discuss right now. There was one other important thing about this exam. Majority of the people thought that this exam was not very difficult. It was moderate. Some even said it was easy. But not all the questions were easy. Some of the questions were definitely previous year questions. They were completely repeats. They were PYTs, but all of them had a twist. And we'll be looking at those twists in this particular session when we're going to discuss the radiology questions. So this first question is the easiest of them all. And we've been talking about this n number of times. The question was, the best investigative modality for ureteric calculi is. And we've talked about it before. For all sorts of urolithiasis, the investigation of choice has to be an NCCT KUB. Now, why is NCCT KUB the investigation of choice and not a CECT KUB? Because we don't need to give contrast. First of all, contrast is not going to give any additional information. And secondly, if you give contrast, then it can overshadow the calculi which can be present in kidneys, which can be present in urinary bladder or the ureter. So here the answer is NCCT KUB. The other options easy to eliminate. Ureteroscopy is an invasive modality, so it can't be investigation of choice, and ultrasound is not the investigation of choice for calculi. It's the investigation of choice for hydronephrosis. I hope you remember this. For hydronephrosis, the investigation of choice is an ultrasound. But for all sorts of calculi in the urinary tract, the investigation of choice has to be an NCCT KUB. And this was a direct repeat, and we've discussed this n number of times. This is a snapshot of what we discussed previously in our lecture sessions, where we discussed that the investigation of choice for urolithiasis is nothing but NCCT KUB. I hope everybody of you would have got it correct. Now, coming on to the question number 2. This question had so many keywords. I mean, it was a long stem question, a lot of clinical integration. A 65-year-old diabetic patient, word is diabetic, then presents with difficulty in breathing and pleural effusion. His CT is showing tree in bud pattern of nodules. Tree in bud. I hope you remember what is tree in bud. Tree in bud means you have small nodules which are present in branching fashion like this, giving rise to this tree in bud appearance. And why does it occur? It occurs because of endobronchial spread of a lesion. Endobronchial spread of a lesion. Typically it is seen in tuberculosis, and in tubercular endemic country like ours, a primary differential in a patient who's coming to you with all these symptoms along with this tree in bud appearance is TB. But here there was a glitch. And what was the glitch? Pleural fluid analysis shows lymphocytosis and, more importantly, low ADA levels, low ADA. So this was something which was a bit confusing, because in TB you expect ADA levels to be high in pleural fluid, in acidic fluid. Now, biopsy of the hilar lymph node of the patient is done, and the examiner wants to know what can you expect in the biopsy. So this is a question which has got a lot of integration. There is integration with medicine, typically respiratory medicine. Then there has got something to do with radiology, because we have CT shown, radiology, and finally we have something to do with pathology, because all the options which are given are related to pathological terms. So when we look at this particular question as a whole, the first differential still is tuberculosis in my opinion, because in our country, if you find anybody with fever, with pleural effusion, with lymph nodal enlargement, then the primary suspect is tuberculosis. And on the icing on the cake is this tree in bud appearance, which we typically see in TB. One question, or one option I should say, which could be considered equally important is fungal hyphae surrounded by lymphocytes, because fungal infections can also present with similar picture with pleural effusion. Sometimes they can also present with nodules. But looking at the question as a whole, the most probable answer in this particular case has to be this necrotizing epithelioid granuloma secondary to tuberculosis. Now, This was the snapshot of our discussion on pulmonary tuberculosis, when I told you that in cases of reactivation tuberculosis, you can find either a tree in bud appearance or cavitation, and this tree in bud appearance represents nothing but endobronchial spread of the TB. Look how beautifully this tree in bud appearance can be appreciated in this particular CT scan, when you can see multiple nodules which are arranged in a tree in bud fashion, typically in a branching fashion. Now, question number 3, again, a direct repeat. I think this was the second easiest question of them all after the investigation of choice for urolithiasis. So there is a 64-year-old patient who's presenting with cough, dysphagia and regurgitation of feces for 7 months. And he also complains of bed breath. These are the key terms: halitosis, regurgitation and dysphagia. And the icing on the cake is examiner has given you a barium swallow of the patient. Now, the only different thing about this question was, in this barium swallow, the examiner had given you an AP image where you could see that there was a contrast-filled outpouching arising from the proximal esophagus. So the answer is pretty certain. There is no doubt about the answer. I think everybody of you would have got it correct. It is nothing but a Zenker's diverticulum. Why is it a diverticulum? Because we can see that there is an outpouching arising from the proximal esophagus. Can it be achalasia cardia? Certainly not. Achalasia cardia is associated with dilated esophagus, and the narrowing is at the level of the G junction, where you have what? You have the bird beak sign. CA esophagus presents with irregular luminal narrowing, filling defect, shouldering and irregularity of the mucosal edge, and we get another sign here which is called as rat tail sign. And diffuse esophageal spasm, definitely not. In diffuse esophageal spasm, you're going to find concentric rings. You're going to find something like this, typically called as the corkscrew appearance or the Curling's esophagus, whatever you call it. So this was easy question. The answer in this case is pretty much clear. It's Zenker's diverticulum. This is the snapshot of our radiology lectures where we discuss Zenker's diverticulum in great detail, and I hope everybody of you would have got it correct. Now, let's come to the next question, which was a bit difficult question. Now, in this case, the examiner had asked you to identify a vessel which was marked on an MR angiogram. So, in the first look, this question might seem difficult, but if you have a look at this MR angiography carefully, then probably you're going to get the answer itself. Now, if we see this vessel, it is lying most exterior. Where is it originating from? So you see it's originating from the external carotid artery because it's lying outside. What is this artery which is forming circle of Willis here? This is the internal carotid artery. And if you see carefully, this branch which was being asked is actually arising from the external carotid artery and not from the internal carotid artery. Now let's have a look at the options. Middle meningeal artery, superficial temporal artery, ophthalmic artery and posterior auricular artery. So one option which you can clearly eliminate is ophthalmic artery, which obviously doesn't arise here, and it is not a branch of the external carotid artery. Now, if we look at this particular artery, look how is it traversing. It is traversing on the outer aspect, typically in the temporal region. So if you remember or recollect your knowledge of anatomy, the two terminal branches of ECA are what? They are maxillary artery and they are superficial temporal artery. So this was another question which had got a lot of integration. The integration in this case was not from a clinical subject, but it was from anatomy. So if you know the terminal branches of ECA, you can solve this question because this particular branch that was being shown here was arising from the external carotid artery. And since it was traversing in the temporal region, the answer in this case has to be superficial temporal artery. Now, coming on to the next question, which was a bit controversial. A 65-year-old female, after undergoing trivial trauma, now the keywords are trivial trauma, presents with multiple fractures. So whenever you have fractures after trivial trauma, you know that you're dealing with a case of a pathological fracture. The radiographs of which have been shown. So these are the radiographs which were shown in which there were fractures involving the femur and the tibia, and there was another radiograph in which you could see that there was almost complete destruction of the femoral head along with some destructive lesion which was involving the iliac bone as well. So let's have a look at the options. The options for brown tumors, disseminated TB, eosinophilic granuloma, and metastasis. Now, eosinophilic granuloma, we talked about this before, is a disease of childhood. So it's out of question. Now, the three options that are provided all make sense. But when we talk about these type of fractures which are involving the shaft of long bones, usually we don't find a disseminated TB in shaft of long bones. So again, this is going to be somewhere down the list. Now, what are we left with? We are left with brown tumors and metastasis. When we look at the age of the age of the patient is 65 years. And because we could see this lytic area, which was a large geographical lytic area, as people had told me, in the region of the iliac bone, it is more likely to be metastatic, typically because the age of the patient is on the higher side. So again, it's a controversial question in which, in this case, brown tumor is also one of the options which could be correct because it is also seen in patients who are more than 50 years of age. But looking at the question in totality and looking at the radiographic image, the most probable answer in this case would have been a metastasis. So this was all about the radiology questions that were asked in this INI-CET November exam. I hope all of you would have got majority of them correct. All the best for the results.